Tony is from Helicon Health. He's going to talk with us today about kind of connecting Colin and Tony's presentations about artificial intelligence and how that can help us with predictive outcomes and basically in the area, in this case, of Afib. So if you could give every single patient that has an atrial fibrillation, if you could give them something that would help them avoid their stroke, this is what Tony's been working on in Helicon Health. So thank you, Tony.
Oh, thanks, Sean. Good day, everybody. Good to see you. So I'm here to talk about how we're using machine learning to help improve the stroke pathway, in particular the stroke prevention. So where we're focused, we've got a lot of pressures pulling us in different directions as a digital health company, but my overwhelming belief is that of the 15 million strokes that happen each year, 80% of them are preventable. And yet, unless we do something dramatic to make a difference, there will be another 15 million people having a stroke this year, and next year, and the year after. So what we've observed is that there are some very useful tools which we can put into practice, and we are already doing that. The work that we're doing stems from a great deal of work and research at University College London in the Centre for Health Informatics and Multi-Professional Education. So we're a spin-out from the world of academia. I have to say I'm the only non-academic amongst the team. Everybody else is professors and PhDs. We have a really great team. But it's my pleasure to deliver the message and to explain how we're actually going about this in practice. So the World Health Organization statistic in the largest study of stroke worldwide showed that 80% of strokes are preventable, and they happen as a result of about 5 or 6 known and modifiable risk factors. So my very simple mind said, well, if we could measure, if we know what the modifiable risk factors are, and we know them for each person, then perhaps we could measure them for each person, work out which of those factors were at play for that individual, and devise a program which would actually help progressively to coach and help that individual to modify those risk factors. And you might even involve their clinician, who knows. But we're very much of a belief that patients and people spend 99% of their time in their own or with their family or at work, and the time of the clinician is very valuable, but actually the clinician is not going to do it for them. They may prescribe medication which improves, they may help with that golden moment, the compassionate approach that Colin was just describing, which has really got the patient's attention at a particularly crucial time. So that golden 2 minutes, I believe, that a clinician has with patient is actually just that extra impetus sometimes to get people to decide to change their lifestyle, to stop smoking, to reduce a few kilos, and perhaps not have that extra glass of whatever. So we think that this patient-powered world is it's an exaggeration, but we think there is an opportunity to encourage and to help people develop the knowledge, the skills, and the confidence with tools to make a difference. Just a little explanation for those of you who are not cardiovascular professors. The heart beating away normally, 62 beats a minute at the moment, hopefully, is receiving blood. Blood is receiving oxygen through the lungs, and then it's pumped out around the body, and that oxygenates and keeps us all going, doing our daily stuff. And so sometimes, and this is not just confined to old people, but sometimes the heart develops an uneven rhythm or an arrhythmia. And one of those arrhythmias is atrial fibrillation, or Afib as it's known. And the issue here is that the blood starts to clot. Well, it starts to pool actually in the atrium, the left atrium in particular. And as it's pumped out, the pump, as as the heart as a pump is kind of misfiring a bit. It's a little bit like I describe it, the old fuel pump in my Morris Minor. It used to go tick, 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 and I'd have to hit it with a stone and just, you really got to know this device. And I think my analogy, at least, is that when the heart starts to misfire, it's not really pumping properly. And that's why the blood is starting to clot. And then the pump mechanism pumps the clots out in, which can go to the brain or the lungs or anywhere else. So that's a real problem. And therefore, it's most important to detect when the heart starts doing this. And the problem with that is that people can't necessarily feel it. So it's described in medical terms as asymptomatic. It is sometimes asymptomatic. Actually, sometimes people describe having AFib as like my heart was trying to jump out of my chest. So it's not always the same for everybody. And also that it is what's called paroxysmal, so medical terms, but basically it's not always beating unevenly. The arrhythmia is not always present. And that is very confusing for people because they go to their doctor. Once again, my Morris Minor story. Whenever I went round a corner, the car would start to judder. And that particular episode was that the coil had sprung a leak, and it was only when you were going around the corner that the oil would either cease to cover the necessary, and so the car was uneven. Well, in this term, sometimes the arrhythmia is there, sometimes it's not. And Sod's law says when you go for a pulse check or an ECG, it's not there. So more often than not, these arrhythmias do not get detected. And that's a problem because the outcomes for people who have an arrhythmia and experience a stroke are really not very good at all. So this is something that you just do not want to happen to you. I'm not going to dwell on all the gory details because you can read for yourself, but it's a most serious condition. And it is also representative of the fact that the cardiovascular system as a whole is not operating well. And so the chances of you being discharged if you do have an AFib-related stroke and making it home as opposed to a care home are very slim. The other thing is that AFib is growing in terms of its incidence. It seems to be growing very, very fast, not just amongst older people, although there is definitely an age-related incidence. But it does seem to be happening, strokes and AFib seem to be happening to younger people. It could be because of recreational drugs, actually. It could be as a result of a number of things, but it's not very well understood yet scientifically. So what we've done is we created, this is not rocket science, we created a platform called Stroke Prevent. And we thought, well, first of all, let's focus on detection, because the easy place in terms of the low-hanging fruit, in terms of the 15 million people experiencing a stroke, there is a very substantial underdiagnosis rate. And yet modern technologies like the one I'm wearing and others are actually able to detect arrhythmias quite well. I just met a lady this morning who came up to me and said, well, actually, I've got a device where just by looking into the phone, it has a CE mark diagnostic. So I'm going to talk to her after this presentation. Another one I'm talking to, they have a camera-based system which will measure 5 of your vital signs there and then just by looking into the camera. So there's all sorts of great stuff coming through. All of this is powered by AI and sensor technology, detecting patterns in data. So detection is one aspect of our platform. And I will show you an example of the way in which we're working with Oxfordshire, as a matter of fact, in England, on that. The next one is protection, and there we've long delivered clinical systems for healthcare professionals to monitor and manage the whole process of stroke prevention, of titration of medication, of recommendation according to so precise and personal. Now we're delivering apps, so we were one out of 450 companies that applied to be awarded a design and build contract by the NHS to design the patient self-care app of the future. And then correction and possibly perfection. That would be a good destination, but let's just say correction. So we have a range of e-learning, so we have to take our workforce, our healthcare professionals, our doctors, our nurses, our healthcare assistants, and our patients with us on this journey. And so we have to find ways of providing those people with a safe environment in which to learn new technology, in which to play with apps, to make mistakes, to talk to friends, to discuss, because that's the learning, the way that learning happens in practice. And often, unless you go through that process and take time to make sure that everybody is confident with the tools that they're using, they don't want to appear stupid in front of the patient. They want to make sure that it's going to work and know what to do if it doesn't work. And so we provide a nice e-learning environment which is designed to be very friendly to do that. Once again, my detect, I think it's having a bad day. It must be day 3 of Arab Health, because this particular graphic keeps sliding down, but not to worry, we won't. This example in Oxfordshire, it's quite interesting. They have 550,000 people in Oxfordshire, so this is a population health analysis. What we did, we have access to 60 million health records. Actually, it's more than that. It's the health records for 60 million people, but actually there's about 6 billion records that we're able to access. So it is the single largest electronic health record database anywhere in the world. And what it enables us to do is to find what we call the missing and the likely. So I like to simplify things as much as possible. And so just to tell you what the missing and the likely, and the top headings and the top 2 right-hand columns there, what that represents, so missing, we define as people who have received a diagnosis for one of a number of conditions, but for whatever reason that diagnosis, which is made in hospital, has not been translated into treatment in general practice. And we sort of understand the reasons for that, or some of the reasons for it. Sometimes, for example, a patient's diagnosed in hospital with an atrial fibrillation, goes to the general practice and it's not showing. So it doesn't get picked up, it's paroxysmal. But other things could be that when you're in hospital for a wrist or a knee or elbow or whatever it is, you're having surgery and you get a battery of tests. You have several ECGs. They're really trying to make sure that you're not going to die on the table with from the anesthesia. And they're also checking your blood pressure. So they take your vital signs probably more during that sort of fairly intense period of hospitalization than you would normally have in a year or more. And all those data get coded, so because it's how the hospital gets paid. But the principal reason for the admission and the principal reason for discharge is what everybody's focused on. So when the general practitioner receives the patient back into their care, they will often focus on the principal, the resolution to the principal reason for admission. And a lot of the other surrounding information gets missed. This is in the NHS. It may be different in your circumstances. So we're not suggesting this is a perfect process, but we are suggesting that once you understand why the process isn't working, you can progressively improve it. So this is a part I see as an opportunity for a quality improvement program. So cutting to the chase, in Oxfordshire, actually I'll just describe likely, if I may. So I described the missing, and that's quite easy. That's the difference between one and the other. The likely is a little bit more complicated, but if you'll sort of bear with me, I'll try to explain. So if you have access to the health records of 60 million people, some of them will have a diagnosis, let us say for atrial fibrillation. And what we can do is we can, using neural networks, we can look at all of those people, what we call the clinical signature of all of those people who have a diagnosis. And then we can say, now show us all the records for those people who don't have a diagnosis but who share that clinical signature at a series of thresholds. So we can, in Oxfordshire, we identified, I think it's nearly 2,700 people, 2692, people who are likely to have atrial fibrillation because they share symptoms in common, or patterns of behavior, or patterns of admission, or blood pressure. So we actually look at 1,600 different variables in that network, and it's learning all the time. So in essence, we realize that we don't want atrial fibrillation. We realize that we'd like to be detected if we do. This is a means of identifying people who are likely to have it so that you can invite them in, you can flag their record so that each time they come in they have a pulse check. You might give them access to an ECG machine to use at home. They may have a weight scale which has an arrhythmia detector. So there's lots and lots of ways in which you can encourage those people to monitor their own condition, and when it's picked up, to come in and get it treated. So these are just a few. I'm not going to dwell on the individual devices because there is a plethora of them, and fortunately there's more and more of them coming to market. Some of them have CE mark or FDA approved diagnostics, some don't, some just have indicators, but to be perfectly honest, I mean, the Apple Watch, the new one's coming out with an AF detector, and I'm sure there's no end of others coming down the track. And then the other moving parts. So there's a lot of medication. So if patients and people are given medication, some is medication that they're prescribed, some is self-administered, and some is for all the right reasons. So alcohol's a good relaxant. Sometimes doctors, you read in the paper that a little bit of alcohol is very good. So then sorry, I'm standing right in front of the picture. But then there's, herbal supplements, ginseng and St. John's wort. Now, the unfortunate thing is that all these medications, A, contraindicate, and secondly, a lot of the formal medicines like let's say Xarelto or warfarin, actually less so with warfarin, but probably Eliquis and amlodipine. Let's say amlodipine because it's less controversial than the others. But the average, Professor Judith Hibbard from University of Oregon, did a study which said that actually on average only 30% of people take their medication as according to the instructions on the pack. And that's not good if you're taking hypertensive medication. It's really not good if you're on Xarelto or Eliquis, or if you're on warfarin. I mean, for example, if you miss one of Eliquis and you decide to, miss it for a couple of days, the last thing you want to do is to take 2 or 3 to try to catch up. Wrong. So the instructions on these packets and inside the packets are really, really important. Now, how many people just get those tablets, rip the medication out because it stops you getting at the tablets, and throw it away? Don't even look at it. Me. But it is actually very important. And so one of the things that we are focusing on is how to communicate that information to people. Chances are that the doctor will mention this at the time of prescribing, but if you're anything like me, you're in such shock at the idea of having to take tablets for life. If you're like me, then because you're in shock, you go home, have a cup of tea, sit down, watch TV, recover, and forget. Or you might remember for a few days, but compliance tails off. And so we have to find ways, and one of the things we're trying to do is to work out how to do that, to encourage people to actually maintain behavior. It could be the chatbots that Colin was talking about. There's a variety of different things that we're trying. So, picture of me eating my lunch and doing my email. So, society and lifestyle is also very much a part of this. So it's just been shown, there's a lot of data coming out which says that pollution, air pollution, particularly NOx, the microparticulates that come from diesel, are starting to cross the blood-brain barrier, and that is potentially a cause of stroke. So once again, we can start to measure that incidence, we can start to measure it down to the individual car, we can start to perhaps alert people that they may be not doing themselves as much good as they think they are cycling down the road on a busy highway. So quick introduction to John. One of the things that we're working with this company on at the moment is the creation of longitudinal health records, in essence, in a population. A lot of this came out of the accountable care initiatives with Obamacare. So the creation of accountable care meant that one needed to generate records according to particular registries, in particular organized in registries, and then to start to apply intelligence to those registries. So this is a quick flick through John's story. Meet John. He was experiencing some shortness of breath. He went to the doctor. They didn't discover anything. A little bit later, he was up a ladder and he fell off. He had some dizziness and he fractured his arm. He went to the doctor and actually they admitted him to hospital for surgery. And this was the time where they actually discovered that he had an arrhythmia. So they were giving him more tests over a longer period of time. They realized. So he had his arm fixed and plated. And he also had diabetes, by the way. And what they put all his records from the hospital system into the GP system. The doctor prescribed, actually in this case, warfarin. He was offered this opportunity to self-manage and chose to go down the route of using apps. And one of the apps that we're working on, as I mentioned earlier, we were awarded a design and build contract for the NHS. And so we've built an app called Vivo. And Vivo is in the process of being released and tested actually with the Stroke Association and some others. So John was also equipped with one of these devices. Some of you have seen those. This is just basically a home blood monitoring, INR testing. The way that we went through this, in order to try to capture what people really felt about apps, understanding much more about what they like and dislike about technology, what they would and wouldn't use. We went through a series of patient-centered design processes. So we held about 10 workshops over a 3-month period. We also included clinicians in some of these, not actually the same workshops, because clinicians often don't want to talk in front of patients, and patients don't really want to talk in front of clinicians. So we split the two up. There were some clinicians who attended the patient workshops as well, but we gathered a lot of feedback, and as we were gathering those feedback, that was put into the design, an agile Scrum design, and so that enabled us to keep moving that forward. And each time there was a new encounter or session with patients, we'd be able to show them a new version, get their feedback, send them an email, they could click on a link, they could see the app, they could give some feedback and so on. It was really a nice process. So that's how Vivo was created, and a lot of that interacts with the population health registries. On the correction side, one of I mentioned earlier, just working with the workforce, upskilling, development of confidence, knowledge, skills. We find actually a lot of healthcare assistants are very keen to use our patient information. They don't want to study, to the level of being a doctor or a nurse. They just want the right level of information so that they can interact better with patients when they meet them. So we've created a nice online learning environment, and that can also be manifested onto your phone as well, and it all keeps synchronized. What we're trying to do is to take some of the essence of that learning, because not everybody wants to do like a formal course. And so we're trying to sometimes make that information available in micro-learning. So we're just sending people context and time-sensitive tips in very small bites, just to try and get that process of change going and to keep it going. So thank you very much indeed. If you have any questions, I'd love to take them. Thank you for your attention.
Any questions for Tony?
Thanks a lot for this presentation. So I'm interested more on the protection side and the detection side of the protection and detection side.
Yes.
So can you elaborate a bit more? What are the protection and detection risk factors that you are using? Would you involve genetics, for example, or is it merely family medicine?
No, very good question. So if I could just repeat the question just to check that I got it right. So in the detection and the protection, what are the risk factors that we're looking for, and does that include genetic and lifestyle factors? Is that right? Yeah. So great question. The principal risk factors, one is arrhythmia. So the principal risk factors for stroke, actually 50% of stroke risk is hypertension. 20% is an arrhythmia. But if you have an arrhythmia and an arrhythmia-related stroke, you tend to have a much worse stroke. So your outcome is likely to be much worse. So that's why it's so important to catch those arrhythms. Other modifiable risk factors, other risk factors, diabetes, as a matter of fact. Diabetes causes atrial fibrillation. I don't think it's the other way around, but you have AF-related diabetes. Heart failure. So a lot of people who have AF actually don't die from stroke. They die from heart failure. So more people die from heart failure than stroke. Other factors, particularly smoking, really, really bad. And what I'm gathering actually in the Middle East is that the rate of smoking, partly because of shisha, you're actually consuming the equivalent of 2 packs in one shisha pipe. So although it may seem, leisurely and enjoyable and so on, the effect on your cardiovascular system is pretty catastrophic, or can be. Alcohol, pollution, obesity. The funny thing is, I'm always asked about stress, and actually it's not written down that stress per se is a risk factor, according to the World Health Organization. However, I think the lifestyle issues related to stress are perhaps alcohol, tobacco, lack of exercise, too much focus on work and not enough on walk. So I think stress is probably a factor. But as far as genetics are concerned, there are some significant spikes in incidence in AF and AF-related strokes around the world. So in particular in southern India, actually in the Middle East, very high rate of strokes. In China also, in the Hasidic Jewish population, I don't know why, but some very significant differences. And I think more than anything else, I think if you have a particularly high genetic risk, or it's deemed to be the incidence of that particular condition, AF say, is very high, then that should mean that you should be more regularly screened. Also, family history is an important factor there. So that's... We do, yeah. We collect all these risk factors at a population level and at an individual level, and we bring the two together. Yeah, we do the maths.
Thank you, Tony. Thank you very much.
That's a great pleasure. Thank you.
Tony Bowden.
Thank you.